Understanding heart failure with reduced ejection fraction. Heart failure with reduced ejection fraction, HFrEF, also known as systolic heart failure, is a complex clinical syndrome characterized by the heart's inability to pump blood effectively due to impaired contraction of the left ventricle. This leads to a decrease in the ejection fraction, the percentage of blood pumped out of the left ventricle with each heartbeat. Causes of HFrEF. 1. Ischemic heart disease. The most prevalent cause of HFrEF is ischemic heart disease, IHD, often resulting from myocardial infarction or persistent ischemia. 2. Hypertension. Chronic high blood pressure places an increased workload on the heart, eventually leading to structural changes and impaired contractility, contributing to HFrEF. 3. Valvular heart disease. Abnormalities in the heart valves, including stenosis, narrowing, or regurgitation, leakage, can disrupt blood flow and contribute to ventricular dysfunction. 4. Primary myocardial diseases. Various conditions directly affecting the heart muscle, such as dilated cardiomyopathy, hypertrophic cardiomyopathy, and myocarditis, can lead to HFrEF. Impact of HFrEF. 1. Reduced cardiac output. The primary consequence of HFrEF is a reduction in cardiac output, the amount of blood the heart pumps per minute. 1. This leads to inadequate blood supply to meet the body's metabolic demands. 2. Forward failure. Decreased cardiac output results in insufficient blood flow to organs and tissues, leading to symptoms like fatigue, weakness, and reduced exercise capacity. 3. Backward failure. The impaired pumping ability of the left ventricle causes blood to back up into the pulmonary circulation, leading to congestion in the lungs. 3. This congestion causes symptoms like shortness of breath, especially when lying down, orthopnea, and paroxysmal nocturnal dyspnea, a sudden and severe shortness of breath that wakes individuals from sleep. Diagnostic criteria for HFrEF. The Framingham criteria are commonly used to diagnose heart failure in population-based studies. These criteria include major and minor criteria, with the presence of 2 major criteria or 1 major and 2 minor criteria suggesting heart failure. Major criteria include paroxysmal nocturnal dyspnea, orthopnea, neck vein distension, rales, cardiomegaly, and acute pulmonary edema. Minor criteria include ankle edema, night cough, dyspnea on exertion, hepatomegaly, pleural effusion, decreased vital capacity, and tachycardia. The vicious cycle of HFrEF often triggers a vicious cycle of events that further worsen cardiac function. 1. Neurohormonal activation. The body attempts to compensate for reduced cardiac output by activating the sympathetic nervous system and the renin-angiotensin-aldosterone system, RAAS. 1. This leads to increased heart rate, vasoconstriction, and sodium and water retention. 2. Fluid overload and congestion. While initially beneficial, prolonged activation of these compensatory mechanisms can cause fluid overload, further increasing venous pressure and congestion in the lungs and other organs. 3. Ventricular remodeling. Persistent neurohormonal activation and increased workload on the heart contribute to structural changes in the left ventricle, including hypertrophy, thickening, and dilation, enlargement. 3. These changes further impair contractility and worsen HFrEF. NYHA classifications and stages of heart failure, including management of advanced cases. The sources offer a detailed look into the classification and management of heart failure, particularly heart failure with reduced ejection fraction, HFrEF. Understanding the NYHA Functional Classification System. The New York Heart Association, NYHA Functional Classification System, is widely used to categorize patients with heart failure based on their symptom severity and functional limitations. It provides a practical way to track changes in a patient's condition over time or in response to treatment, and facilitates communication among healthcare providers. While the system is subjective and relies on patient-reported symptoms, it offers valuable prognostic information, with increasing NYHA class associated with a higher risk of morbidity and mortality. Here's a breakdown of the 4 NYHA classes. 1. Class I, mild. Patients experience no limitations during physical activity. 1. Ordinary physical activity does not cause undue fatigue, palpitation, or dyspnea, shortness of breath. 2. Class II, mild. Patients experience slight limitations during physical activity. 2. They are comfortable at rest, but ordinary physical activity results in fatigue, palpitation, or dyspnea. 3. Class III, moderate. Patients experience marked limitations during physical activity. 3. They are comfortable at rest, but less than ordinary activity causes fatigue, palpitation, or dyspnea. 4. Class IV, severe. Patients experience symptoms of heart failure even at rest. 4. Any physical activity exacerbates their symptoms. The ACC/AHA stages of heart failure. The American College of Cardiology, ACC, and the American Heart Association, AHA, have developed a 4-stage classification system for heart failure, focusing on the progression of the disease from risk factors to advanced disease. This system emphasizes the importance of prevention and early intervention in heart failure management. Here's a summary of the 4 stages. 1. Stage A. Patients are at high risk for developing heart failure but do not have structural heart disease or symptoms of heart failure. 1. This stage includes individuals with conditions like hypertension, diabetes, coronary artery disease, a family history of cardiomyopathy, or exposure to cardiotoxic drugs. 2. Stage B. Patients have structural heart disease but no symptoms of heart failure. 2. Examples include those with left ventricular hypertrophy, previous myocardial infarction, or valvular heart disease. 3. Stage C. Patients have structural heart disease with past or current symptoms of heart failure. 4. Stage D. Patients have advanced or refractory heart failure requiring specialized interventions. Managing advanced heart failure, Stage D. Patients with Stage D heart failure represent the most challenging cases, as their symptoms persist despite maximal medical therapy. Management focuses on alleviating symptoms, improving quality of life, and considering advanced therapies. The sources highlight several key aspects of Stage D heart failure management. Meticulous fluid management. Strict control of fluid retention is crucial in Stage D heart failure. This often involves aggressive diuretic therapy and may necessitate fluid restriction. Referral for advanced therapies. The sources emphasize the importance of timely referral to specialized heart failure centers for patients who might benefit from advanced therapies, such as 1. Cardiac transplantation. This is an option for carefully selected patients with end-stage heart failure who meet specific criteria. 2. Ventricular assist devices, VAAD. VAAD can provide mechanical circulatory support as a bridge to transplantation or as destination therapy for patients ineligible for transplantation. End-of-life care discussions. The sources recognize the importance of open and honest discussions about end-of-life care with patients and their families. These discussions should address treatment preferences, advance directives, and the potential role of hospice care. Symptom relief and comfort care. Providing symptom relief and maximizing comfort are paramount in Stage D heart failure. This may involve the use of medications for pain management, dyspnea relief, and anxiety reduction. Key considerations in advanced heart failure management. 1. Individualized treatment plans. Treatment strategies for Stage D. Heart failure should be highly individualized, taking into account patient preferences, comorbidities, and overall prognosis. 2. Multidisciplinary care. Effective management of advanced heart failure often requires a multidisciplinary approach involving cardiologists, heart failure nurses, palliative care specialists, social workers, and other healthcare professionals. 3. Patient and family support. The physical and emotional burdens of Stage D. Heart failure can be overwhelming for patients and their families. 3. Providing comprehensive support services, including counseling, education, and access to support groups, is essential. Conclusion. The NYHA Functional Classification and ACC/AHA staging systems provide frameworks for understanding and managing heart failure. Stage D heart failure requires specialized expertise and a focus on symptom relief, quality of life, and consideration of advanced therapies. Prognosis. The prognosis for HEF-Ref depends on the severity of the condition and the presence of other comorbidities. It is a serious condition associated with significant morbidity and mortality. A study on the impact of left ventricular function on survival after myocardial infarction showed a markedly increased mortality rate at 6 months for patients with an ejection fraction below 40%. Treatment strategies. 1. Lifestyle modifications. Lifestyle changes, including dietary sodium restriction, weight management, regular exercise, and smoking cessation, are essential in managing HEF-RF. 2. Pharmacological therapy. Diuretics. These medications help reduce fluid overload and alleviate congestion. ACE inhibitors, ARBs, and beta blockers. These drugs improve cardiac function, reduce mortality, and slow disease progression in HEF-Ref. Mineralocorticoid receptor antagonists. These medications can further reduce mortality and hospitalization rates in patients with moderate to severe HEF-Ref. 3. Device therapy. Devices like biventricular pacemakers and implantable cardioverter defibrillators, ICDs, can improve symptoms and reduce the risk of sudden cardiac death in eligible patients. 4. Surgical interventions. For select patients, surgical options like coronary artery bypass grafting or valve repair replacement may be considered to address underlying causes of HEF-Ref. 5. Heart transplantation. This is reserved for patients with end-stage HEF-Ref who do not respond to other therapies. Racial disparities in HEF-Ref. It's important to acknowledge the existence of racial differences in heart failure therapeutics. African Americans experience a higher incidence of heart failure at younger ages compared to other racial groups. This disparity highlights the need for further research to understand the underlying factors and to develop tailored treatment strategies that address these disparities. Summary: HEF-Ref is a serious condition that requires comprehensive management strategies. While current therapies can improve symptoms and prolong survival, there remains a need for continued research to develop more effective treatment options and to address racial disparities in heart failure care.